Hello everyone, and welcome to the final section of our final unit of the semester. Congratulations on making it this far. We are going to talk about therapeutic orientations. So throughout the semester we've discussed quote-unquote normal psychology, and this unit touches a lot on abnormal psychology. And so when we talk about abnormal psychology, it's also important to talk about therapeutic techniques and interventions to kind of help ameliorate some of the issues that people have when they have different psychoses. How we can improve their daily functioning, how we can fix their maladaptive cognitive patterns and behaviors. It's very important not only to identify the disorder, but also to help, take away that stigma, offer them solutions that are, evidence-based as much as possible. And so that's what we're going to talk about with therapeutic orientations. And so what I want to focus on today is just talking about the most widely practiced approaches to psychotherapy. We're going to be very general with them. And just looking at history, goals, key techniques, and empirical support for the different theories. So we're going to look a lot into different paradigms. You won't have to know too much history, just like who's associated with it. But if you remember from Unit 2, all those big names and different perspectives in psychology, you should be fine. You should be able to infer what the upcoming sections are about. We're also going to consider the impact of emerging treatment strategies in mental health. So we're looking at how these different trends are going to affect people. Now, that's not going to be a part of this PowerPoint as much. This PowerPoint is going to focus mostly on the different strategies, but make sure you read your text because that's going to talk about the impact of emerging treatment, such as virtual treatment, such as, a lot of people are quarantined right now and they're engaging in virtual classes. Well, the same can be said of virtual therapists, making things more accessible for people, maybe in rural areas who don't have the accessibility to the appropriate mental health resources. So, first we're going to talk about psychoanalytic therapy. So, what do we remember about psychoanalytic therapy? Freud, okay? So, Freud, we're going to look at unconscious desires and childhood experiences. Those are the big trademarks of psychoanalytic therapy. With Freud specifically, he looked at how our unconscious impulses in terms of sex and aggression affected how we form our personality and how we develop different psychological disorders. So we've talked previously about the id, ego, and the superego in our personality section, right? These are the different structures of a person's self. Your id is it's the little monster hidden in the recesses of your mind that's going to deal with your urges for those sexual urges, the aggressive urges. It's very animalistic. Your ego, well, let's go to the opposite end of the spectrum. Your superego is going to be the superhero who understands all the social norms and how you should carry yourself, and if you want to fit in and abide and be an upstanding citizen. And your ego is going to kind of be the difference between the two. It's going to find a compromise between what do I want and what is socially acceptable. Now, with Freud and psychological disorders, he believed that if there was too much conflict, unconscious conflict between these structures, this would result in stress and therefore a psychological disorder. Let it be known that a lot of, Freud had some very controversial disorders that he labeled specifically to women based on stereotypes. So this is going back to our second unit and looking at how early psychology didn't use the best sample to be representative of what they were trying to discover. They often used white, educated males to kind of generalize those results to everybody else. But anyway, I digress. Just know that it's not without fault, but I am just looking at the basics for the sake of our PowerPoint. But if you do have questions on that, just let me know. So with psychoanalytic therapy, right? We're looking at those unconscious desires. Well, the methods that we're going to use in psychoanalytic therapy, unfortunately, don't have a lot of empirical support. And why is that? Because the therapist's job in psychoanalytic therapy is to interpret things for the client. Or so, for example, if we were engaging in free association, this is a task in which maybe if I'm the therapist and you are the client seeing me for a certain disorder, maybe I give you different keywords and I want you to tell me the first thing that comes to mind. Well, I'm going to let you ramble on a list of words. If I say mother, maybe you'll say beauty, wonder, evil, right? Whatever you're going to say, the therapist is going to kind of, in a psychoanalytic approach, is going to interpret your associations and what that means. So this type of therapy is very driven by the therapists. Not saying they have some kind of motive or ulterior motive, but it's just that's their job to try to interpret all of the information that you're giving them because they think it's the unconscious, those unconscious desires coming out. And this is seen in dream analysis, which we've talked about previously, and states of consciousness. We have latent and manifest content. So sometimes psychoanalytic therapy would look at people's dreams because this was believed to be a way that our unconscious would try to access our conscious mind in our sleep. We didn't have as much control over those cognitive processes, so it's kind of like we could tap into the unconscious more on some level. So you have your manifest content, which is going to be what actually happens in the dream, and the latent content is going to be the meaning of that dream. And then there's also, so again, just remember that for the methods, it's going to rely heavily on the interpretation of the therapist. What could be an issue with this? Well, that can be highly subjective, right? What one therapist may interpret from someone's dream may be entirely different from another therapist. So it lacks the empirical backing that we're kind of looking for in this day and age. And there's also these ideas of psychoanalytic therapy as kind of as a therapist being aware of these ideas of transference and countertransference. So when psychoanalytic therapists are looking at all these unconscious desires coming out, this includes any feelings that the client may have, maybe towards their dad or their mother, and they might transfer them to the therapist. That's this idea of transference, is kind of displacing those emotions onto the therapist. And countertransference, if you can kind of guess, is when the therapist places their feelings of someone else or different feelings from the client back to the client. So it's kind of being aware of how you direct these feelings of other people who maybe reminded you of your therapist. Maybe this person's therapist looks like their dad. So maybe they'll transfer those emotions to their therapist. And the therapist is going to take those emotions into consideration when interpreting the data that they're getting from the client. Psychoanalytic and psychodynamic theories, types of therapy take a long time. They're very extensive and in-depth. And while you get a lot of interesting information, again, it doesn't really necessarily have the empirical support. Now, with humanistic and person-centered therapy, this is kind of, think of it as the opposite end of the spectrum with psychoanalytic therapy, in that it is driven by the client. So this was developed by Carl Rogers, who had the premise that all people have the potential to change and improve. Remember how I always talk about humanism as being like the hippie, everyone can reach their potential, we all have free will, wonderful paradigm, thought paradigm or psychological paradigm or perspective. Well, that's the idea that Carl Rogers is one of the big names we associate with this. And that's because he really wanted to put the power of the therapy session into the hands of the client. And so whereas psychoanalytic and psychodynamic rely heavily on the interpretations of the therapist, this type of therapy is very client-led. It's appealing to the client because they have this idea that they're taking control of their life. So with humanistic type of therapy, there's this idea that people's behavior is mixed matched with their true self. Like maybe they're putting on a facade of some kind, or they're acting. And this is what can lead to mental health problems. This is kind of the foundation that underlies this perspective. And so the goal is to discover one's self-worth and discover who they really are and how they can match those behaviors to who they really want to be and present themselves as. So if you're acting one way, or if you discover who you are, discover that self-concept, you want to act in a way that matches that. And so that's what we're looking for here, is finding that balance. And so with humanistic type of therapy, the therapist's role is to be a facilitator of understanding. So letting the client enter a judgment-free zone and a place of understand, to help them get to a place of understanding about who they are without guiding them in a certain direction. So it's very free in that way. So for example, humanistic foundations can be seen across multiple perspectives of psychology, in that a lot of times therapists are non-judgmental because they're trying to create an area, a space where the client feels free to express themselves in order to truly heal. For example, if someone comes in and they say that they are a pedophile, and you are a therapist, if you judge them, you more often than not, you will not be able to help them, because your job is to be non-judgmental in helping people recover and explore themselves. Because as we know, a pedophile is someone who finds themselves attracted to children. They do not always act on these feelings. So a pedophile is different than a child molester. So I'm just kind of making the differentiation there for the purpose of, putting yourself in the place of a therapist who may have to work with situations that may make you uncomfortable, right? And that's what they go through training for, is to be non-judgmental or strip away that judgment in order to help someone seeking that help. An important aspect is that non-directive therapy. Like I said, you're not guiding the client in a certain direction towards what you think is their self-discovery. You're helping them, talk through their experience to discover what it is they need for themselves. And giving them unconditional positive regard. So you're going to view them positively no matter what. You're going to assist them in moving through the process. One of the things that's kind of controversial about this is that with humanistic and person-centered therapy, it's often a kind of cookie-cutter approach, a one-size-fits-all, so to speak. The same method is used for an array of different problems, which could be good and bad. If we use an eclectic approach and taking pieces from different paradigms, but it's not really tailored towards different experiences in the individual. So sometimes some situations may call for that. So that's kind of a drawback to this perspective. Then we have cognitive behavioral therapy, which is huge. It's a family of therapeutic approaches whose goal is to alleviate psychological symptoms by changing their underlying cognitions and behaviors. So this is important. It's seeking to focus on the present. It's not so much looking at, what happened in childhood, or what happened with your parents when you were 5, right? We're looking at the present. So what thoughts are you having now? What thoughts are occurring? Oh, I just realized I messed up this little stream of sequence here. So let's ignore that, because thoughts and cognitions are the same thing. Excuse me. So anyway, you have these different cognitions, and you're going to have feelings about those. That's what I meant to say. Sorry, I'm not going to edit this. So thoughts. Thoughts are going to occur. These could be intrusive thoughts, like the example I used of excessively washing your hands. So maybe you have the thought, I need to wash my hands, or else I'm going to die because of the germs that are on them. That's a thought. So then there's a cognition. What I meant by I should have put affect here. So replace this second part with affect, because you're going to feel a certain way about those thoughts. Maybe that thought is very anxiety provoking, thinking you're going to die if you don't wash your hands. And so it's going to lead to a behavior. And that behavior is trying to fix those feelings you're having. And so it reinforces the thought pattern and it repeats the cycle again. And so with cognitive behavioral therapy, we're looking at those maladaptive thoughts, maladaptive affect, and maladaptive behavior, and we're trying to help the client see how they're thinking in an abnormal way, so to speak. To approach things from a different cognitive perspective. And this requires a lot of effort on behalf of the client to understand what they're thinking, how to change your thought patterns. Because thought patterns, as we've studied, they're so entrenched, they're so pervasive, the way we think about things. So changing them requires a lot of effort on our part. And so with cognitive behavioral therapy, and it's like any other muscle. In order to recognize those thought patterns, we're going to have to practice and flex that muscle. So with CBT, often there are homework assignments given, like a journal or a log. There may be kind of different prompts depending on what kinds of thoughts the client is seeking to address. In the case of the hand washing, maybe the therapist starts by having the client journal a little bit about what they were feeling when they had to wash their hands that day, or how many times that day they felt they had to wash their hands, different things like that. And it's going to be tailored to the individual. There's also rational emotive therapy, as well as reappraisal and cognitive restructuring. So these kind of look at how, that's the focus, reappraisal, cognitive restructuring. So restructuring how one thinks about something. Reappraising, remember when we talk about appraisal, is adding a feeling to something. We appraise a situation, we assess it. So reappraising our feelings surrounding that thought. As well as exposure therapy. So this could be, say someone's afraid of spiders. It's a good example used in our text. Exposing them to the prompt or the thought or the thing that is driving them to have these maladaptive thoughts and behaviors, and slowly working their way to confronting it. Now, if someone has a horrible phobia of spiders, you're not going to do a Maury show and flood them with a bunch of spiders, because that's what they did on the Maury show. I don't know if y'all ever seen that when they addressed the fears. But you may have them first visualize seeing a spider. Now, and then move to maybe handling a plastic spider. And then maybe you move to holding a little spider in a jar. So you're systematically exposing them to these different stimuli. And in the process, you're trying to change how they view that situation in terms of their thinking about it, the behaviors they engage in, and the affectivity that develops as a result. So with acceptance and mindfulness, this is another approach, and it is based on looking at the present self as well, and it's rooted in Buddhism, because it looks at those meditative practices. So it's kind of taken that bit from those approaches. And so it's a non-judgmental yet attentive mental state. And so it's about assessing one's bodily sensations, thoughts, and the outside environment, compared to cognitive behavioral therapy, where we're trying to address those maladaptive patterns. We're trying to change them because, they're not good for us. We want to change them. We want to change those behaviors, etc., etc. Mindfulness and acceptance does not confront those behaviors, but accepts them. It says, hey, you know what? Yes, I had this bad thought, or yes, I'm having these intrusive thoughts. But you know what? That doesn't mean, these thoughts are going to define me. So it's very, you have to be very present in your metacognition to recognize and understand. And a lot of these techniques are going to take practice. So with that self-regulation of attention, you're able to recognize those thoughts you're having, but also you're not trying to change them. You're just accepting them as part of the situation and kind of moving on and staying in that present moment and trying not to, maybe you had a bad thought about killing a family member. Well, you know you'd never do that, but it's a thought that came into your head that was scary. Well, with mindfulness and acceptance and mindfulness, you notice that thought and you say, hey, you know what, I had this bad thought, but it doesn't mean that I want to do that. It was just something that popped into my head randomly, and it was a little odd, but I'm going to keep moving on because that doesn't define anything about me. Very different from a psychodynamic perspective. But fortunately, it's been seen a lot of pros because patients' acceptance has grown with the prevalence of meditation and different meditative techniques, how they've kind of pervaded our society in recent years. And the con is that evidence for some of these techniques for different disorders tends to be a little lacking, but it's growing in terms of anxiety and mood disorder. TX just means treatment. Sorry. So we're seeing a lot of advances in specifically how this relates to anxiety and mood disorder, which, if I'm going to put in an anecdote, kind of makes sense if we're looking at mindfulness and meditation and trying to bring back the calm, especially with anxiety disorders. Other treatments, we look at pharmacological treatments. We've talked a bit about those. Basically, there are going to be different drugs available to people based on what kind of disorder they have and how they're going to be treated. This is where we see the difference between a psychiatrist and a psychologist. Psychologist is specifically trained in therapeutic techniques. Psychiatrist is a medical doctor who can prescribe medications. Psychologists cannot prescribe medications. Now, there are some states that are trying to have it as an additional certification, but largely, no. So make sure you know the difference between those two. Because often they'll kind of work in tandem. Because sometimes people rely solely on pharmacological interventions. Sometimes people don't want to go to therapy, but they'll take anti-anxiety medications. Whereas some people do both. Where some people just do therapy. Right? So there's all these different sorts of treatments, and how they're going to be utilized is going to depend on the individual, the disorder they have, the comorbidity, excuse me. So basically, do they have other disorders? Because treatment interventions are going to change if you have schizophrenia and depression versus depression and anxiety. And looking at the treatment availability. So what's available to the person, maybe based on what insurance will cover, etc., etc. And finally, you have integrative and eclectic therapy. This is like the therapy buffet, okay? So it's just taking in a bunch of different methods. You don't have to strictly stick to one type of therapy. If you follow more psychodynamic perspective, that's great. That doesn't mean you're only going to use, free association, dream analysis, etc. You may draw from humanism in that you want to create a safe, non-judgmental space. Maybe you do want to talk a bit about mindfulness in helping that person recognize their thoughts. And no, mindfulness doesn't make sense. Don't use that example. But maybe you want to draw from behaviorism. So if you believe that a certain behavior is a result of reinforcement and consequences, then you may adapt from that perspective. Although it may not necessarily line up. Behaviorists now are much different than behaviorists of early psychological times. But oftentimes, therapists are going to draw from methods that kind of line up. So often how do I want to say this? An early psychologist, you wouldn't have a therapist. Early psychology, you wouldn't have a therapist using behaviorism approaches with a cognitive approach, right? Because behaviorism was very strict back in the day. But now we have cognitive behavioral therapy because it's recognizing that behind different behaviors, we do have different cognitive patterns. And so, But that's a whole topic in and of itself. Just basically think of it as like a buffet. You have all of these different techniques, all these treatments, even pharmacological interventions being used, and it's just a matter of how you're going to pull together those resources to benefit you as a therapist or the client. What works best for that client based on what they've told you, what you've assessed as their needs, etc., etc. But the most important thing to remember with therapy is that we're trying to get people back to functioning, because a lot of times these psychological disorders can be debilitating, and we it's not to we have to strip away the stigma, because even though we're getting better about talking about mental health, because that's a really big effort and push in our current climate, there's still a bit of stigma, especially if, like, younger people, maybe their parents don't believe in talking about depression, right? So it's important to give people the help that they need, strip away the stigma, to talk about these things, and to help people function at a level where they can be comfortable and not have to suffer through those egosyntonic kind of symptoms. I hope I used the right one on that. Anyway, I hope you all enjoyed this unit. Let me know if you have any questions. I know this is a lot of video, so I appreciate you watching it for those of you who do. Have a great week.